Adrenal lesion in Connecticut syndrome. Adrenalectomy in a case of Connecticut syndrome due to a cortical adenoma. Connecticut syndrome due to a cortical adenoma is frequently detected among hypertension in the young. Tumor shows circumscribed borders, thin fibrous encapsulation may be identified. The rest of the cortical tissue shows atrophic change, both from suppression and from pressure effect. Lymphoid cells. Tumor cells show polygonal shape and lipid vacuoles, seen as foamy cytoplasm, with arrangement in cords or trabeculae, features seen in normal adrenal cortex. H&E. Another case. Another case with tumor protruding on one side of the gland. Adrenal vein. Normal part of the gland appears atrophic with rather thick capsule. Pleomorphism and nuclear atypia may be present in these benign tumors. This patient had a very small cortical adenoma. Connecticut syndrome. This patient had a very small cortical adenoma that produced Connecticut syndrome. A case of Connecticut syndrome presenting with hypertension and being treated as a case of essential hypertension. Histologic features of cortisol-producing tumor and aldosterone tumor are indistinguishable. Adrenal Cushing syndrome. Hypercortisolism, Cushing syndrome, causes and pathogenesis. Cushing disease. Surgical specimen, adrenalectomy. Cushing syndrome, clinical manifestation. Truncal obesity. Striae. Recovery. Formation of nerve ganglion. H&E. Atrophic change of adrenocortical tissue in both adrenal glands because low ACTH level. Adrenocortical carcinoma. A rare case of functional adrenocortical carcinoma with viralizing effects in a female patient. Histopathologic features are that of high-grade malignancy. Notice the marked pleomorphism and cytologic, nuclear atypia among the tumor cells. Vascular invasion is readily identified. Also a rare case of functional adrenocortical carcinoma presenting with Cushing syndrome. Adrenocortical tumors. Adrenocortical carcinoma, non-functioning. Adenoma with Connecticut syndrome. Adrenocortical tumors. Benign malignant. Majority of cortical adenomas are non-functional and not clinically detected. Functional and non-functional tumors have the same morphologic features. Nuclear pleomorphism may be present. Adrenocortical carcinoma is rare type neoplasm. In functional cases, rare, more commonly associated hyperadrenalism with viralism. Highly malignant, usually large when discovered. Paraganglion system. What is the paraganglia? Small groups of cells formed behind the peritoneum, retroperitoneum, in the connective tissue capsule of the suprarenal gland, in the thoracic, abdominal sympathetic chains, in the urogenital organs, in the epicardium, near and around the kidneys, and elsewhere. Function, probably involved in the production of adrenaline, noradrenaline and acetylcholine. The substances are secreted in the fetus to help maintain the blood pressure. After birth, the adrenal medulla and the autonomic nervous system take over this function. Several paraganglia regress when the adrenal medulla becomes functional after birth, For example, the aortic chromaffin body called organ of Zucker-Kendall located near the origin of the inferior mesenteric artery. The persistent parts are usually fragmented, and the resulting paraganglion cells found in contact with sympathetic ganglia or even some blood vessels. Some paraganglia cells, located near the vagus nerve, the glomus jugulare, are found to secrete acetylcholine. These cells do not show chromaffin reaction, as those of the adrenaline-producing paraganglia such as adrenal medulla, sometimes called non-chromaffin paraganglia. Several paraganglia function as chemoreceptor and baroreceptor, such as carotid body, carotid sinus and aortic body. Clinical significance. Tumors of paraganglia are usually highly vascularized. Size of the tumor may not correlated with severity of symptoms. Paraneoplastic syndromes due to secretion of active substances may present unexpected symptoms due to sudden release of secretion upon manipulation. Histopathology of paragangioma. Cytoplasmic granules may be seen due to richness in mitochondria and/or secretory granules. Chromaffin reaction is useful in detection of chromaffin paraganglioma, pheochromocytoma. Highly vascularized. Tumor cells arrange in groups or clusters surrounded by vascular structures, so-called organoid feature. Pleomorphism and atypia among tumor cells do not determine malignant nature. Adrenal medulla tumor, pheochromocytoma. 0.1% of hypertensive patient having underlying pheochromocytoma. 10% of pheochromocytoma found extradrenal. 10% familial, autosomal dominant. 10% bilateral. 10% malignant. Morphology of pheochromocytoma. Yellow-tan tumor substance. Incubation of fresh tumor with dichromate turns tumor to dark brown, pheo equals brown. Polygonal tumor cells having lobular arrangement or cell ball, zellballen, with highly vascularized stroma, organoid pattern. Cytologic atypia among tumor cells not indicating malignant nature, adrenal medulla, pheochromocytoma. The tumor would become much darker brown color after leaving infixative for a period of time due to oxidation and polymerization of catecholamine similar to that occur in chromaffin reaction. Chromaffin reaction, after fixation in chromate-containing solution, tumor tissue appeared mahogany brown. Pheochromocytoma. Highly vascularized tumor with organoid feature. Rich cytoplasmic granules, the chromaffin granules and mitochondria. Cytologic atypia among tumor cells not indicating malignant nature, Zenker fixed tissue, H and X128. Formalin fixed tissue, H and X128. Due to richness in mitochondria and secretory granules in the tumor cells, the cytoplasm appears granular. Note the brownish hue in the Zenker fixed tissue from chromaffin reaction among the cytoplasmic granules. Variation in size and shape of tumor cells and nuclear pleomorphism are not sign of malignancy in this tumor. Chromaffin granule demonstration by transmitted electron microscope. Chromate treatment H&E. Chromaffin reaction. Cherry red granules in Mallory stain. DEM, membrane-bound electron-dense secretory granules in tumor cells. Adrenalectomy specimen, total weight of 102 grams, showing bulging tumor mass having smooth surface and showing no adhesion to surrounding structures. Part of adrenocortical tissue seen displaced by the bulging tumor to one side of the specimen. Fresh specimen, cut section shows tumor mass having thin capsule. Fresh specimen, cut section shows tumor mass having thin capsule. The tumor occupied the whole adrenal gland substance, thus no part of normal gland identifiable. Tumor tissue shows reddish-brown color with hemorrhagic foci. A central scarred area, arrow, is also present. Capsule, adrenal vein. Adrenal cortex. Formalin fixed, H&E, X8. Adrenal cortex with pressure effect from the expanding tumor. Zenker fixed, H&E, X12.8. Tumor cells arrange in distinctive cell balls, so-called zellballen or organoid structure, among highly vascularized stroma. Comparing staining characters in Zenker fixed and formalin fixed tissue, both with H&E routine stain. Note the brown color tint in Zenker fixed tissue due to the chromaffin reaction. Zenker's fixative contains mercuric chloride, HgCl2, and potassium dichromate, K2Cr2O7. The chemical causes chromaffin reaction by oxidative process and polymerization of catecholamines that make brown color substance. Multiple endocrine neoplasia syndromes, MEN. A group of familial disorders with hyperplasia or and neoplasia of several endocrine organs. Inherited as autosomal dominant traits. Multiple endocrine neoplasia syndromes, MEN.